opportunity to thank you for taking the time out to be a part of the Sickle Cell Foundation and joining with the members of the Sickle Cell community in celebrating Sickle Cell Awareness Month. Today we'll be, as you all know, you are part of our annual lecture. And the title for today's lecture is Management of Sickle Cell Disease, Mainstreaming the Use of Hydroxyurea in Jamaica. As someone living with the condition, I can attest to the fact that management of our pains and crisis or our condition itself really impacts our quality of life on a day-to-day basis. And so we do look forward to the development of new and effective medication, because with the evolve or the implementation of each one, there is an expectation of a new quality of life among persons who are living with the disease. The science and medical care around persons with sickle cell has shown that rapid advancement over the last 20 years, for which we are grateful. We therefore applaud the members of the foundation, the members of the panel, and to you who have taken time to celebrate with us. So without further ado, I will now invite Dr. Tamara Taylor to open our lecture series by offering a word of prayer.
Thank you so much. Pleasant afternoon to you, participants. Welcome. Okay, let us bow our heads in reverence to the Lord. Okay, without him, nothing in this world is possible. Okay. Father God, we invite your presence throughout this lecture as we lean not on our own understanding. Father, you are the creator of all, the healer of all diseases, and the physician of all physicians. We thank you for sustaining us. We thank you for the sickle cell unit and the angels of doctors you have provided for us over the years. Without you, this annual sickle cell lecture would not have been possible. As Dr. ASNANI and her team explore the management of sickle cell disease, mainstreaming the use of hydroxyurea in Jamaica, we pray that the knowledge from this lecture will be well received and practiced by patients and supported by family members. We also pray that the knowledge we garner from this lecture will impact not only the Jamaican citizens, but other people beyond our borders. Father, we express gratitude to all the sponsors of this lecture. Again, grant us understanding and clarity throughout this lecture. And we all say,
Amen.
Amen, amen. Thank you so much.
All right. Thank you, Dr. Taylor, for such a powerful prayer. And at this point in time, I welcome Ms. Moritz Wright, co-founder and vice president of the Sickle Cell Foundation of Jamaica, to bring us greetings and welcome.
Thank you so much, Jebby. Welcome, everyone. Welcome, welcome. Hoping you're all safe and you have not been severely impacted by the inclement weather. It's our pleasure to see you all joining the Sickle Cell Support Foundation annual Sickle Cell Lecture Series. And our lecture theme, as you've heard, is Management of Sickle Cell Disease, Mainstreaming the Use of Hydroxyurea in Jamaica. Most of us know the impact sickle cell disease has had on our lives. And so it's good news with the medicine hydroxyurea. So we expect an informative and, may I say, transformational lecture. So now is an ideal time for you to invite someone to join us. You can't afford to miss this series. Let me pause to acknowledge our Master of Ceremonies, our moderator, Miss Jebby Campbell. Great job, Jebby. Welcome to all our partners from the Ministry of Health and Wellness, Dr. Carol Lord and other executives and directorate, From the Sickle Cell Unit of the Caribbean Institute of Health Research at the University of the West Indies, we welcome the team who have joined us, and we also welcome the members and friends of the Sickle Cell Support Foundation of Jamaica. Our special guest and keynote speaker, Professor MONIKA ASNANI, Director of the Sickle Cell Unit. Thank you, Prof, for agreeing to give this lecture. We're eagerly awaiting your presentation. The work we're doing to advance the quality of life of the sickle cell community, it cannot be underestimated. So wherever you are in Jamaica or overseas, we celebrate you, members of the sickle cell community or sickle cell heroes. So we pause to acknowledge you. You can write in the chat, hashtag sickle cell heroes. Members of the media, ladies and gentlemen, friends and family, it is truly a pleasure to welcome everyone who took the time to join this special event as we celebrate Sickle Cell Awareness Month 2022. Thank you for choosing to spend your time with us this evening. This year is very significant for the Sickle Cell Support Foundation of Jamaica. It marks our 30th anniversary. 30 years ago, two young ladies living with sickle cell, university students at the time, that's Camille Daly and myself, we independently assessed the severe impact of sickle cell disease on so many persons we interacted with. The physical impact, the intense pain and other complications, the psychological impact, the anxiety, depression, and suicidal tendency, yes, suicidal tendencies. The social impact, the high level of unemployment, and the hardship faced by so many persons living with sickle cell. Having assessed the situation, we were motivated to take action. We used our voice. We expressed our concerns to Professor Sargent, head of the unit at the time. He introduced us and we co-founded the Sickle Cell Support Club at the time, responding to the cause. Since April 2015, we've been a registered nonprofit voluntary organization. And I share that context as we should not remain silent when there is a need. As a foundation, we establish our goals to heighten public awareness of sickle cell disease, support persons living with the condition, and to create an environment in which they can thrive and realize their full potential. And we're proud of our progress to date, 30 years later. Some institutions have not withstood the test of time. So we have made some significant strides, just to highlight a few. In 1993, a year after we started, we lobbied the Ministry of Health to restart newborn screening of sickle cell, for sickle cell. Screening began in 1996, and today the Ministry of Health can boast universal screening of newborns for sickle cell in Jamaica. Proud moment. We lobbied the Jamaican government to add sickle cell disease to the NHF, and in 2015, this was done. Again, through advocacy by the foundation, the ministry increased the range of subsidized drugs. This is very significant for many persons living with sickle cell who are unemployed and without health insurance. We've produced a teacher's guide for sickle cell disease and circulated in our schools in Jamaica and shared with our partners in the region. This year, to mark our 30th anniversary milestone, we raised funds and awarded 3 tertiary level scholarships and 6 bursaries for skills training to persons, thanks to our sponsors. And we intend to make this an annual award to impact the lives of underprivileged Jamaicans living with sickle cell, helping them to achieve their educational goals. So if you're listening and you wish to contribute to our scholarship fund, please contact us. Not only that, we started a process to transform the lives of 8 children with sickle disease, ages 11 to 13, who have just transitioned to high school. We launched a mentorship program and assigned each one of them to a mentor, someone living and thriving with sickle cell, to journey with them through high school. We're excited about the potential impact of this initiative. I'm equally pleased to report on the advancements made with the care landscape for sickle cell disease in Jamaica. The Ministry of Health and Wellness is leading the charge in improving the care and outcomes of persons affected by sickle cell disease. Since 2013, that's 9 years ago, sickle cell disease has been included in the strategic plan of the Ministry of Health and Wellness. The Sickle Cell Technical Working Group was instituted with overall mandate to improve the sickle cell program in Jamaica. This includes integrating the care of sickle cell disease into the framework of the Ministry of Health and Wellness. This now sits in the non-communicable disease unit at the ministry. This, of course, is building on the pioneering work of Professor Graham Sargent and the hard-working staff at the sickle cell unit, past and present. You'll definitely hear more from Dr. Carl Lord, chair of the Sickle Cell Technical Working Group. I must reiterate, this is significant and augurs well for the sickle cell community. In closing, as you're aware, September has been officially designated Sickle Cell Awareness Month, observed to increase knowledge and understanding of sickle cell disease. Ultimately, to improve the quality of life, the care and outcomes of persons affected. Yes, knowledge is power. This lecture is so significant as it is intended to advance our knowledge on a game-changing treatment for sickle cell disease, hydroxyurea. This is a medicine that doctors have been using since the 1980s to treat sickle cell. In 1998, the Food and Drug Administration, FDA, approved it for treating adults with sickle cell. And in 2017, they approved it to treat children with sickle cell. Is that a plug? Well, Professor MONIKA ASNANI will tell us more in her keynote address on management of sickle cell disease, mainstreaming the use of hydroxyurea in Jamaica. Ladies and gentlemen, welcome all. Thank you for spending your time with us this evening.
Thank you, Ms. Wright, for such a warm greeting. And as you have indicated, 30 years is a whole lot of years. It means that we can really sit back and look at where we're coming from and where we are, and where we're going. If you are aware, when you're married, there are some milestones that you count in your marriages, right? And when you have reached a 30-year anniversary, it is said that it is signified by giving pearls. And it also means that the union would have been based on a very strong bond. It is also said that it is filled with love, the parties involved are filled with wisdom, and that there is some level of durability. So it means that we have a fire that is burning, and it is our duty to ensure that we keep the flame ignited. So at this point in time, I am going to invite Dr. Carl Lord, Chair of the Sickle Cell Technical Working Group from the Ministry of Health and Wellness, to bring us greetings.
Yes, thank you so much, our chair and moderator, Ms. Debbie Campbell, Ms. Dr. Taylor, who did an opening prayer, Ms. Maureen Wright, co-founder and vice president of the Sickle Cell Support Foundation of Jamaica, Professor MONIKA ASNANI, director of the Sickle Cell Unit, Ms. Camille Daly, founder and president of the Sickle Cell Support Foundation, Professor Knight Madden, co-chair of the Sickle Cell Technical Working Group, distinguished guests, ladies and gentlemen, members of the media, good evening. It is a great honor to speak on the work that has been done in Jamaica as it relates to sickle cell disease and caring for persons living with sickle cell disease. Now, many persons will be able to tell us that we have 19,000 persons living with sickle cell disease, and 1 in every 150 Jamaicans are known to have the sickle cell disease. The Sickle Cell Technical Working Group consists of several parties. We have the Sickle Cell Support Foundation, as Ms. Wright would have said just now. We have the Caribbean Institute for Health Research, of which Prof. ASNANI and Prof. Knight Madden are a part. We have the Sickle Cell Support Foundation, the Sickle Cell Trust, and the National Health Fund, and we collaborate with the regional health authorities. This is to say that this group form an important part as we offer care to persons living with sickle cell disease. What has the care we have offered over this time? We have recognized that over the years, actually every year, there will be about 25 to 33,000 babies that are screened at every hospital within the nation. This includes the private and the public hospital. This gives us a screening within the last year of a 99.6%, and that is great. Our aim is for 100%. Babies, we must know the status of all our children. The Ministry of Health also continues to recognize the vulnerability of our pregnant women living with sickle cell disease. And so at our antenatal clinic, we've been having screening of our pregnant women, and this actually has gone a far way in women recognizing their status. Once they're high risk, once they're positive for sickle cell disease, they are considered high risk and they get specialized care. This can only be done through the collaboration of our internal and our external partners. And so when these babies are born and they have the sickle cell disease, they are linked to care at our health facilities across the nation. And these include all parish, all region have these facilities that care for our baby where they receive their childhood immunization. And what's more is that we were able to offer 5 doses of the pneumococcal vaccine, which is offered by the government of Jamaica to protect the children from severe infection. The important thing here is that we have documentation of the status of the babies in the Child Health Development Passport, and every child that is delivered in Jamaica has one of these books that take them up to 17 years. When we have Sickle Cell Awareness Day or the Sickle Cell Awareness Month, as it is in September, we try to raise awareness. And part of that awareness that we will raise, it includes sessions just like these, of where we inform the healthcare professionals and the public of what is new on the sickle cell disease platform. We have so far completed by Prof. Knight Madden, our co-chair of the technical working group, the needs assessment survey, where they were able to have the needs of persons living with sickle cell disease so that we can coordinate the programs to target these needs. And I think this was very important. We have the consultation form, and patients living with sickle cell disease will soon have a passport when they're seeking care. And these are just a few of the things I want to say that we have been able to offer in collaboration as we offer care to persons living with sickle cell disease. We want to say kudos to the team of persons who would have really dedicated time dedicated a lot of time to create avenues in where we can offer optimal service. And so with that, we can continue talking about what this technical working group has done over the years. But I want to say on behalf of the Ministry of Health and Wellness, the executive body, the Director of Health Services Planning and Integration, Dr. Nadine Williams, and Dr. Melody Ennis, the Family Health Director. Together we bring greetings from the Ministry of Health, and we know that this session will be very informative with robust discussion, and all the best. Over.
Thank you, Dr. Lord. I heard you mention the importance of screening, right? And I am just looking back at when I was an infant, that opportunity was not present with my mother, because my mother found out that I had the condition when I was 2 years old. So I'm just looking at now where it is that we were then compared to where we are now, how it is that you are able to now capture the health history or the fact that these infants are born with the condition from a very early stage, and as such, you are able to advise and inform parents of what to expect and the do's and don'ts regarding growing the child and what they should do as a parent. All right, so without further ado, though, at this point in time, we are at the critical part of our lecture series, and we will be welcoming Professor MONIKA ASNANI, Director of the Sickle Cell Unit. But before I do, let me give you a brief summary of who Professor ASNANI is. So Professor MONIKA ASNANI is a Professor of Medical Science and Epidemiology and Director of the Sickle Cell Unit of the Caribbean Institute for Health Research, Chair at the University of the West Indies in Jamaica. She joined chair in 2003 and has over 18 years experience of working with sickle cell disease. Her focus of research includes 1, psychosocial outcomes of determinants in sickle cell disease, and 2, sickle cell nephropathy. Her work has advanced understanding of predictors of renal function decline in sickle cell disease, and has sought to validate methods to determine the presence of early sickle cell nephropathy. She has validated and tested various tools to examine quality of life in children, adolescents, and adults living with sickle cell disease in Jamaica. She recently led a project to assess the prevalence of nephropathic pain in sickle cell disease and has been the local principal investigator for gene therapy in the sickle cell disease project. She is currently initiating a study to examine the barriers and enablers of hydroxyurea utilization in Jamaica. Prof. ASNANI is a graduate of the University of the West Indies and was awarded her bachelor's in medicine in 1992. Her thesis work leading up to the award of her DM in family medicine in 2006 examined the quality of life of patients with sickle cell disease. In 2014, she completed her doctorate in epidemiology with a focus on epidemiology of sickle cell nephropathy. At the UWI, Prof. ASNANI is a course tutor, examiner, member of the specialty board in family medicine program. She is a member of the Caribbean College of Family Physicians, having served as its honorary secretary for a decade in the past. She also served as a board member of the Caribbean Researchers in a Sickle Cell Disease and Thalassemia Group. Her passion is to do all that is important to improve the quality of life that persons living with the disease enjoy. Without further ado, I now welcome Prof. in delivering her lecture series. I ask that at this point in time, if it is that you have any questions during the lecture, to post them in the chat so that at the end of her delivery, she will be able to answer all your questions and to provide the insight that you want. Prof, we welcome you, and we know that it will be a very impactful and knowledgeable lecture. So at this point in time, without wasting any further time, I now hand over to you.
Thank you so much, Debbie. Thanks so much. Good evening, everyone. Special greetings for Tamara, Debbie again, and all my other friends and colleagues on the call today, on the Zoom link, as well as on all our viewers on YouTube. Dr. Carol Lord, Ms. Wright, Camille is not here yet, but thanks so much for giving the Sickle Cell Unit an opportunity to partner once again. You know, I love the teamwork. So you know how I feel about all of that. I think this is such ideal working together, you know, the foundation, the ministry, the unit, and other people who are just committed and passionate about improving lives of persons living with sickle cell diseases. So I'm gonna try to share. Is that okay? Go ahead and share. And if I do, I was hearing breakup sometimes, and it might just be my internet. I will take my camera off if I need to, if I hear myself not too well. And somebody shout if you're not hearing me either, because when I share, I might not be able to see expressions. So let me share. Go into slideshow. Okay, all right. So I was given the task by Moret mainly to speak today on management of sickle cell disease, mainstreaming the use of hydroxyurea in Jamaica. So I'm gonna start with a couple of slides on some basic information on sickle cell disease. So don't get too bored. I know most of you know this already, but sickle cell disease is one of the most common monogenic disorders worldwide. What does monogenic mean? It occurs due to a defect in a single gene. Now we humans, it is unknown how many genes we have, but we have over 20,000 genes in our body. And so just a single gene, and each one of these genes has millions of components. And it's really just one component in one gene that is defective and leads to this a group of disorders called sickle cell diseases. This disease affects the hemoglobin in our red blood cells. Red blood cells are one of the type of cells in our blood, and that they are what give our blood the color red. And the important their utility is they carry a very critical function, which is they transport oxygen throughout our body. So this disorder, sickle cell disease, affects the hemoglobin, which is a molecule within the red blood cells, which actually attaches the oxygen and moves it around the body. It's a multi-system disorder, which can be quite severe. Multi-system means many, many different systems within our body. So it affects, and you can imagine it's a blood disorder. So everywhere blood flows, this disease can cause problems in. It can lead to acute sudden problems, such as painful crisis, acute chest syndrome, strokes, etc. And as persons with sickle cell disease get older, it may affect organs, our organs, and cause progressive damage. It can damage our eyes, our kidneys, heart, liver, etc. How is it inherited? We said it is a genetic disorder, which means it is inherited. You are born with it. You cannot catch it from anyone. You cannot catch it through a blood transfusion. You can get it no other way except you are born with it. And you inherit the disease from both parents. You do not get it from one parent. Both of your parents, if you look at this mom and this dad, have to have at least the sickle cell trait for a person to be born with SS disease or a type of sickle cell disease. If mommy and daddy have sickle cell trait, as seen here, they can have children who have sickle cell trait, or they have the possibility of having a child who has no abnormal hemoglobin, no sickle hemoglobin, or a normal hemoglobin called AA. So a couple who both of which partners have the sickle cell trait can have children with sickle cell disease, sickle cell trait, or normal hemoglobin, which is AA hemoglobin. So what happens when we have sickle hemoglobin or the normal A hemoglobin? It causes our red cells, which usually look nice and round and donut-like, and it causes those cells to turn into a sickle shape or a banana shape or a crescent moon shape, the sickle shape, okay? And what's so special about having a round shape or a sickle shape is that these sickle cells are very fragile, they are rigid, and they are very sticky. So they can stick together and cause blockage in our blood vessels where blood flows. So they can cause blockage to blood flow. And the fact that they are very fragile means their lifespan is short. So a normal blood cell, we said, looks like a round, nice donut, and they tend to live for about 120 days, whereas a sickled red cell will assume the sickle shape. And these cells have a shortened life, 10 to 20 days. And that's why typically persons living with sickle cell disease tend to have lower blood counts or lower hemoglobin. So just to remind you that sickle cell trait is when a person carries one S gene and one normal A gene. But to have sickle cell disease, you have to carry one S gene with another abnormal gene. The commonest type of sickle cell disease is SS, where both of your hemoglobin genes are abnormal and they're both S. If you carry one S and one C, it is called SC disease, etc. There are many different variants of sickle cell diseases. The commonest is SS worldwide and in Jamaica, followed by SC and followed by your sickle beta thalassemias. There is a huge amount of variability in how persons with sickle cell disease deal with their illness, or is sickle cell disease is expressed within individuals. So typically we know that persons who have the SS type of sickle cell disease or the S beta 0 thalassemia type of sickle cell disease tend to have more severe disease, tend to have a little bit more complications when compared to persons who have the SC or the S beta plus thalassemia. However, even within a genotype or a kind of sickle cell disease, so even within, say, SS disease, so if we have 10 persons with SS disease, some of them might have very mild symptoms and some can have very severe symptoms. So there can be variability even within a particular type of sickle cell disease. Keeps us all on our toes. What's the global burden? What's happening globally with sickle cell disease? We think about 20 million persons in the world have sickle cell disease. That's a lot of people. And every year, over 300,000 babies are born with this sickle cell disease. And really, whereas in developed nations, persons with sickle cell disease are living into their 40s, 50s and more, and so it is in Jamaica as well. But in lower income countries, for example, sub-Saharan Africa, where you have 75% of those babies being born, 50 to 90% of them will not live to 5 years of age. And the health burden of this disease can be reduced through management and prevention programs. What about sickle cell disease in Jamaica? We spoke about it. Dr. Lord, all the speakers spoke to it already this evening. 1 in 150 babies being born in the island alive are born with sickle cell disease. 10% of our Jamaican population has a sickle cell trait, and 15%, another 5% has another abnormal hemoglobin gene. So a total of 15% of our population in Jamaica has an abnormal hemoglobin gene. So 17 to 18,000 or maybe 19,000 persons in Jamaica are living with sickle cell disease, and almost 500,000, over 400,000 persons in Jamaica have some kind of a trait. Jamaica has done fabulously because of these partnerships that I just mentioned earlier on today in its response to sickle cell disease, and we must be so proud. Sickle cell disease was added to the list of chronic illnesses that is subsidized by the National Health Fund. This happened in 2015. 2015 also when universal screening was begun in Jamaica. And these are the clinical care guidelines of the sickle cell unit. This is the second edition that you're looking at, and it is accepted by the Ministry of Health and Wellness for in the public healthcare system as standard of care for sickle cell disease management. So coming closer to the crux of the matter, how do we manage sickle cell disease? Many, many medical advances have occurred in the last few years. So whereas sickle cell disease was first, what shall I say, brought to attention in 1910, that's almost 110 years ago, not a lot was learned in the first couple of decades, but definitely in the last 2-3 decades, there have been many, many medical advances, thankfully. Which means that persons with sickle cell disease are living longer, healthier, happier, with improved quality of life. However, it is a chronic illness, but with good knowledge and teamwork, what we are exhibiting here, it can be managed well. It can be a severe illness, and so it's important to have regular health checks, because during those health checks, we can also identify the onset of complications and try to get a handle on them before they become too severe. So why do we need to go for routine care? Because we will learn that diet is important. We need to make sure we have adequate fluids. I think persons with sickle cell disease know this better than I or any doctors or nurses know this, that we must be drinking well, keep well hydrated. Persons with sickle cell disease, their metabolism is high. They burn off their food very quickly. And they also need adequate vitamins and minerals. So fruits and vegetables are a must. However, what we are noticing in the last few years in Jamaica, as well as in the rest of the sickle cell disease populations, definitely in the developed countries, is that whereas in previous years, we always thought of people with sickle cell disease being slim or thin. Now we are seeing weight gain happening in children and adults with sickle cell disease. In our last couple of years, the studies this unit has been doing, almost a quarter of our patients are becoming overweight and obese. So that's a burden that we need to look out for and pay careful attention to, because that will bring its own problems. During routine care, we will talk about medications. Persons might need to have pain medications. Person might need to be on hydroxyurea or other medications for sickle cell disease, what we call disease modifying treatments. They might need medications to protect their kidneys. They might need folic acid, not everyone with sickle cell disease folic acid, and they might need vitamin supplements, among other medications. During your routine visits, you will be taught what we call anticipatory guidance. Before pain occurs, how do you anticipate pain? How do you prevent pain from happening? And if pain is starting, how do you quickly begin to put your management protocols in place at home? Leg ulcer prevention and management, priapism management. So management, looking out for and managing these complications as soon as you feel these complications are happening in your body, and then keeping what appropriate medications to keep at home, and etc. So you will learn about these anticipatory guidance points during your routine visits. Disease education is a must. The more persons with sickle cell disease understand their illness, the better they self-manage. Really and truly, your doctors don't need to know about your illness more than you know about it. We may know some technical stuff, we may understand the way medications work a little bit more, but you can know a lot about your disease, because the better you understand, the better you will self-manage. And for a chronic illness, which means an illness that a person has to manage over years and years, and sickle cell disease is something we have to manage from infancy, from the time persons are 4 months of age, they can start having problems. The more you learn about your illness, the better you can manage it yourself. Different age groups have different needs and health issues. So persons need to have education on a regular basis so they can understand what to look out for. And we said the other things already. Can we prevent a pain crisis from happening? Can we recognize emergencies? Can a mother recognize when her baby is getting into an emergency, a sickle cell emergency? disease education is important. During routine care, you will also have other education and empowerment strategies that are discussed with you that can help you to reduce school absenteeism, age-appropriate counseling. When young children with sickle cell disease are becoming adolescents and becoming more independent, they need another level of counseling. Persons need to have reproductive counseling, genetic counseling. They need to get psychological and social support. All of this in an effort to empower them to manage their illness better. You will also be advised about how often to visit and how often to have your follow-ups. You might need to be referred to certain experts, some specialists, if there's some kind of a concern that your kidneys may be at a little stress from your sickle cell, you might need to be referred to a kidney specialist. If the heart is showing some strain, you might need to see a heart specialist. So visits and follow-up checks are important. At those checks, your immunizations will be updated. You will get your prescriptions and you will get your follow-up appointments. Adults with sickle cell disease should be seen at least every 6 months, and children with sickle cell disease, definitely younger children, need to be seen every 3 months, etc. So all of this is important during your routine checks. And during your routine care, you will also get some psychological and other social issues being addressed, because the presence of a chronic disease will not only impact your physical health, but it impacts significantly on mental health issues and other social challenges. So we need to be aware and manage as healthcare providers. We need to be aware of them and assist in our patients in managing them. Patients themselves need to be aware. Parents and communities and family members need to be aware and help us to manage. So, can sickle cell disease be modified or cured, or do we just need to live with it, face the crisis when it comes, and go to the hospital and so and so and so? But can it actually be modified or cured? Absolutely. Many measures are out there now that can modify your disease. Chronic blood transfusions is a mainstay. There are medications up to just about maybe, what shall I say, about 5 years ago, hydroxyurea was really the only medication used for modifying sickle cell disease. But in the last 5 years, other drugs have come on board. And then more towards curative therapies, there's the bone marrow transplantation, which you would have heard of. And gene therapy is being examined and studied very widely and very quickly in seeking a cure for sickle cell disease. So talking just a quick slide on transfusion therapy. So this is blood transfusions. Really, it is a mainstay. It can help with reductions of complications and improvement of quality of life, because if this is a blood problem, if sickle cell disease is a problem in the blood, then definitely kind of exchanging that blood for normal hemoglobin blood can take care of a lot of the complications. But blood transfusions, definitely chronic or recurrent blood transfusions, come with their own problems. For example, there may be inconsistent blood supply. Definitely in Jamaica, we have a problem with blood supply. Then when persons get transfusions, there may be episodes of transfusion reactions or adverse reactions. And then if you get transfusions over and over,
Yes, our teacher ready?
You may have, Tamara, is it your mic? Right, so you may have iron overload. The iron in the blood can get stored in the body, and that can be very toxic. So transfusion has its own problems. As I said, in the last 5 years, rapidly, after almost 40 years of nothing but hydroxyurea, since 2017, there have been 3 new drugs that have been approved for the management of sickle cell disease. L-glutamine, which is really a supplement, it can be found naturally in foods as well, has been found to reduce painful crisis and reduce hospitalizations, and is taken orally twice a day. This is the product name, Endari. We do not have it in Jamaica, but however, L-glutamine powder can be available, can be found in some health stores in Jamaica. Voxelotor or Oxbrita is the trade name, was approved in 2019. It's a tablet taken once a day, and it can increase your hemoglobin or your blood count levels and really reduce your hemolysis or breakdown of your red blood cells and really just improve sickle cell disease. Crizanlizumab or Adakveo was also approved in 2019. Amazing, two huge medications that got approved in 2019 that has shown to reduce vaso-occlusive crisis or painful crisis or other crises. And it increases the time between two different crises. So if you're gonna have crisis every 4 months, this might increase that time to crisis every 8 months or 10 months. But it's taken as an IV, intravenous, once a month. So these are the newer drugs. None of these, voxelotor nor crizanlizumab, are available in Jamaica. And on the horizon, there are many drugs being studied all the time, and there are different phases in trials, and it remains to be seen, and a lot more than what I have on the slide here. But just wanted to show you that there's a lot of work happening in developing new drugs for managing sickle cell disease. The hematopoietic stem cell or bone marrow transplantation is the only curative treatment, first used over 40 years ago, was initially mostly confined to children who had a matched donor in whom the procedure is thought to be the safest, but use in adults has also begun. So bone marrow transplant can cure sickle cell disease, but there are limitations. You need to have a matched donor for the most part, and only about 1 in 5 persons with sickle cell disease may have a match. There may be serious immunological side effects, meaning because it is a graft you're getting, a foreign bone marrow you're getting in your system, you, the person who has gotten the bone marrow transplant, may reject it, what we call graft versus host disease or graft rejection. And of course, you have to be given chemotherapy, which are strong medications, which can come with its own problems. But it has shown excellent results and continually is being improved in the system. So it's definitely a curative therapy. It's not available in Jamaica, nor in most parts of the Caribbean. Gene therapies, as I said earlier, are under examination. They are still under research, and there are different types of gene therapies. As Debbie said, we have been engaged in a gene therapy trial in Jamaica over the last 6 or so years. Is coming to an end now, and there are other trials happening around the world in gene transfer. Okay, in gene therapy, you do not need a donor. Your own cells, your own stem cells from your bone marrow are corrected or edited in some way and given back to you, so you don't have that problem with graft rejection and so on. And gene editing, so gene transfer, gene editing, different technologies being examined, and the results are definitely coming out encouraging. But I left the best for last, and this is what we are here for today, which is hydroxyurea. Okay, and for me, this is the game changer. It is a game changer in the management of sickle cell disease. If you remember nothing else after today, right? Because you can come find out from anybody, call Dr. Lord or call Moret or call anybody at the unit, any of our doctors or the nurses. When I keep saying unit, I mean the sickle cell unit at UWI. Or ask your GPs about hydroxyurea. But even if you remember nothing about hydroxyurea, you say it's a game changer. It can be a game changer for me if I have sickle cell disease, okay? So remember this, it really has made a vast difference in the lives of persons living with sickle cell disease. So if I was to tell you in one slide, what hydroxyurea is that it is an excellent medication. It's a simple tablet or liquid for children that is taken once a day by mouth. The medications are readily available in Jamaica. The NHF, the National Health Fund, covers it. And you know, for National Health Fund, any drug that they cover, the discount for children is double. So if for adults, each tablet has a discount of $32, then for children, it will be a double discount. It does need close monitoring by your physician early in treatment. There may be toxicities or side effects that can occur, but they are usually mild and totally reversible. We cannot use it in pregnancy, okay? And if you look at this slide of a sickle cell person's blood spot under the microscope, you will see these are his or her blood cells before they started taking hydroxyurea. Not a lot of them look nice and round, like donuts, but after taking hydroxyurea, blood spot from the same patient shows very nice donut-looking cells. You can hardly see any sickle cells. So if I was to tell you everything in one slide, then this is a slide. Excellent medication. And the way it works, I told you about hemoglobin A, which is the hemoglobin that is considered normal. We spoke about hemoglobin S, which is a sickle hemoglobin, which is present in persons with sickle cell disease. But there's another kind of hemoglobin. The fetal hemoglobin is the hemoglobin that we have in our bloodstream when we are in our mother's wombs, okay? When we are growing in the mother's womb. Fetus or fetal hemoglobin, and it converts into hemoglobin A soon after birth. But in persons with sickle cell disease, it doesn't convert to hemoglobin A. It converts instead to sickle hemoglobin or hemoglobin S. But what was found in very early days is that some persons with sickle cell disease who happen to continue to have certain levels of fetal hemoglobin or hemoglobin F, they hardly had any sickle cell disease problems. And how hydroxyurea works is by increasing fetal hemoglobin levels. These are our friends. Professor Russell Ware has worked with us at the sickle cell unit. He is an investigator, a sickle cell researcher and doctor in the United States, and a friend of the unit for the last 15, 20 years. And he is the guru when it comes to talking about sickle cell disease. And one main way hydroxyurea works is it increases fetal hemoglobin level. And once fetal hemoglobin levels increase, then the effect of sickle hemoglobin just drops. It gets canceled out, okay? And it does a lot of many other good things that are abnormal in sickle cell disease. It seems to be custom built for persons with sickle cell disease. It's an old drug, and within sickle cell disease, it has at least a 30-year experience. And for 30 years, it was the only drug used in sickle cell management, as I've said earlier. At the sickle cell unit, what are our indications for starting hydroxyurea? If we have a person with sickle cell disease who has recurrent painful crisis, they need to be on opioids, it's interfering with their work or school, they end up getting admitted regularly, we would offer them hydroxyurea. If they have recurrent multiple attacks of acute chest, once they have more than 2, we will advise them to use it. Or if they get one acute chest syndrome that lands them in hospital, strong recommendation for them to go on hydroxyurea. If their blood counts just continue to remain low and they don't have any problems like kidney disease, which can drop their hemoglobin, then we would recommend it. And at our unit, if children get a stroke, they need to be started on hydroxyurea, or if their transcranial Doppler examination, which is an ultrasound in the brain, of the brain, which can identify children who are at high risk of getting a stroke, we offer hydroxyurea, but we have to avoid it in persons, men or women, who are looking to get a baby in the next couple of months. And if they are pregnant or they refuse to use contraceptive, we will not recommend hydroxyurea. If there's active liver problems, they cannot take hydroxyurea till that gets sorted out. And other than those strict criteria, there are a lot of emerging criteria. It can be as simple as a parent coming and saying, "Doc, I really want my child is sickle cell disease. I want him or her to get hydroxyurea." Because really, we can offer it to children who have not yet shown many complications, but people with milder genotypes might be able to use it if they seem to be showing complications of, for most part, hydroxyurea is recommended for persons with the more severe genotypes, which we said are SS or S beta thalassemia. But if you have a SC who has severe complications, then it can be considered, even though we don't have as strong evidence to back it up. Okay, and for other unusual complications, kidney disease, eye disease, we can start hydroxyurea. And what has it shown to do in the last 25, 30 years of its use? In adults, it has shown that it can reduce by 50% the number of painful crises and the severity of painful crisis. It reduces acute chest syndrome. It reduces the need for getting blood transfusions or being hospitalized. And same in infants and children. It will reduce painful events, acute chest, transfusions, hospitalizations. And in a long-term follow-up study, it showed a 40% reduction in death. And these are significant, and this evidence just keeps building all the time. Persons always worry about side effects. Thanks, Dr. King, for your slide. And there are a couple of slides that, that Dr. King really helped me with, so thank you. But really, some of the common side effects, we know them and we can anticipate them. And that's why we said you need to be monitored a little more regularly and cautiously in the first couple of weeks and a couple of months of starting hydroxyurea. And then there are some rare side effects, which I say, as it says, are rare. A lot of the common side effects are totally reversible. Okay, I think, as I say to persons living with the disease, work with your doctors, work with your healthcare teams, let them take on some of the worry and help you out with use of hydroxyurea. Definitely with reproduction, there are concerns, or patients feel, is it going to, men will think, does it affect my fertility? Some concerns about sperm development, but it's difficult to decide because severe sickle cell disease will also affect sperm, will also lead to sperm abnormalities. So, and remember, hydroxyurea is being used for persons with more severe disease. So it's very difficult to say if they would have had any problems just from their sickle cell disease. And definitely, as I said, we cannot use it in pregnancy. So if a woman is taking hydroxyurea for a few years, but now wishes to get pregnant, we need to stop hydroxyurea for about 3 months before she becomes pregnant. So with all of that being said, I'm trying to look at my time as well and hope not to go too much over time. With all those lovely things that we say about hydroxyurea, and we strongly believe about hydroxyurea, and it is not only Jamaica that believes about hydroxyurea. Globally, it is understood that hydroxyurea is a game changer. Why is it that hydroxyurea use in Jamaica is still not optimal? So if we look at the sickle cell unit, which is an expert center, a center of excellence for the management of sickle cell disease in Jamaica, and this was these numbers, we looked at these numbers a few months ago, but over 3.5 years, if the unit saw close to 4,000 patients, we only had about 380 patients on hydroxyurea. That's less than 10% of our persons coming to the unit were on hydroxyurea. The ages that were on hydroxyurea range from babies 1 year of age to elderly 71 years of age. More children were on hydroxyurea than adults. Most of them had SS disease, as you can imagine. Okay, so we saw at our unit that just about 10% of our sickle cell population is on hydroxyurea. But remember, not everyone who has sickle cell disease must be on hydroxyurea. If you're having very mild disease, hardly any problems, you don't really need to be on it. But a large number of our persons need to be on it, and really only less than 10% are on it currently. And if you look at the cost of hydroxyurea, we worked out some costs, and with the NHF card, which every person in Jamaica who is living with sickle cell disease, whether it's a baby or a child or an adult or an older adult, not an elderly, but an older adult, they should have their NHF card. They should be registered with the NHF. And with the NHF card, for a regular size adult, say 60 kilo adult at a normal kind of dose, because dose varies for sickle cell, for hydroxyurea, you might just be paying about $3,000 a month for the drug. Okay, it can be a little less or it may be a little bit more. But compared to other drugs, say glutamine, the L-glutamine that we spoke about in the US, in Jamaica, this is the cost in Jamaica. If you were to take a proper dose, it would run you close to 16,000 Jamaican dollars. And crizanlizumab and voxelotor, if they did come to Jamaica, why don't you want to try to calculate that? It's probably close to $1 million for a month's supply. So hydroxyurea, thanks to the assistance with the NHF, is very low cost and is available. So why the poor uptake? Why, and this is not just seen in Jamaica, this is seen worldwide. Why the poor uptake? It may be because there's hesitancy on the part of the providers healthcare providers, the doctors who are writing your prescriptions, or on hesitancy on the part of the patients. I don't know if I want my child to be on it, doc. I hear say it can cause cancer. Well, hydroxyurea does not cause cancer. Why the association with cancer? Because hydroxyurea, even though it's used in sickle cell disease over the last 30 or 40 years, it's a way older drug, and it is used for certain blood cancers, but it does not cause cancer. But there are concerns patients have. Women might say, well, I want to have a baby. And you know, men with sickle cell might say, I want to have a baby and I don't want my sperm to go back, you know. And then families. So there could be hesitancy on part of your healthcare providers or you yourself or your families. You may not understand the drug so well, and so you don't feel very confident in using it, right? And once, because it is a drug that needs to be used every single day, and we don't know for how long, possibly for life, or at least while you're going through, you know, more severe kind of complications, because it has to be taken every day, there is found to be poor adherence, missing doses for days or weeks or months sometimes. And it may be intentional poor adherence because you're just tired of taking it every day. And many of us in Jamaica feel, Lord, doc, I don't want my body to get used to it. I don't want to get addicted to the drug. No such thing. Or it may be unintentional. You simply forgot. Lives are very, very hectic. And I can't say that if I have to take a drug every day, that I'm very good with it. But I have to devise ways of reminding myself how to take that dose every day. In fact, a patient of mine taught me some stuff to do last week, and I'll tell you about it later. The reasons for poor uptake also may relate to low awareness of its benefits. How many of you listening know about the need and the usefulness of hydroxyurea in managing sickle cell disease? How many patients know about it? How many parents know about it? So it just may be low awareness. And so kudos to the Sickle Cell Support Foundation for asking for this talk on hydroxyurea, because hopefully we can spread awareness of its need and its benefits. And as we said earlier, reasons may be related to the perceived risks. It may be a financial burden. So the drug has a cost. It's not for free. It can be free in the public healthcare system, okay, if it is available in the public healthcare facilities, which it should be. But there are also the costs associated with monitoring. Usually these persons on hydroxyurea will need few more blood tests than persons who are not taking hydroxyurea. So they can be a financial burden, and then there can be other burdens, the cost of transport for more frequent visits, missing work. Parents might have to miss work. Adults with the disease may have to miss work for their more frequent visits to see the doctor. And so how can we improve uptake? And these are some of the strategies that have worked in other settings, as you can imagine. So study by McGann et al., and this came out just last year, showed that if healthcare providers had a careful and deliberate commitment to guidelines for standards of care, for example, our sickle cell clinic guidelines, then they can have much better uptake of hydroxyurea in their patient population. So if we were to be really deliberate about disseminating our guidelines, okay, and we encourage training of healthcare providers if they're so requested, then we can spread awareness and about the benefits of hydroxyurea. Having guidelines in your hand, it makes it very easy for you to just flip a page and see, this is what I'm supposed to do to start a person on hydroxyurea. And so it's easier to manage. Better information sharing about benefits of and risks. So it was found that if healthcare providers did proper consenting, and really at the time when they are recommending hydroxyurea to a patient or a parent with a child with sickle cell disease, and if they went into the details about benefits and risks and showed them the balance, then it can dispel a lot of patients' concerns about side effects, okay? So you show them and evaluate with them the much larger potential benefits than much smaller issues with side effects, because really side effects are they can be big lists, but how many of us are going to get them? Really very few, and most of the side effects are easy to manage. So If you have engaged, empowered patients and caregivers, when knowledge of efficacy of hydroxyurea is increased, uptake will increase. If we improve access to sickle cell disease specialists, if all over the island of Jamaica, in any health center, you had doctors writing this, but they knew that if they had a little question, they could really pick up their phone and call or email a sickle cell specialist doctor, then that can allow them to feel more confident in prescribing the drug. And this was also from a study that came out recently. Access to comprehensive primary care facilities or medical homes. If a patient, and all patients should be registered in a medical home, everyone with sickle cell should have a medical home to deal with their illness. Persons who are registered in a medical home will do better with taking hydroxyurea. And you need to examine implementation issues for your own region. So for our own country in Jamaica, our barriers may be different from the barriers in the United States or UK or in Africa or in India. So research is important to understand what's happening and what are the factors that are hindering use of hydroxyurea. And the Sickle Cell Unit has actually designed a study, and we are just going to launch the study as soon as we can get a little funding and get all our approvals in place. We are going to initiate a study to examine exactly that. We want to look at what are patient and caregiver factors. How do they access, do they accept hydroxyurea? Are they adhering to hydroxyurea? Are they satisfied with their care? And healthcare provider factors, what are the doctors, the nurses, the pharmacists? Do they understand the need for hydroxyurea? What are their attitudes about the use of hydroxyurea? And the health system factors to look at accessibility. Is it available? Is it accessible? What is the cost like? So I think this is my last slide. In summary, sickle cell disease is a genetic, potentially debilitating illness with collaboration between engaged and empowered patients and families, knowledgeable and committed healthcare providers, and proactive and responsive healthcare systems. Outcomes can be amazing. And I would like to say, I can really put my neck out to say that we are moving along these three aspects in Jamaica. We should be so proud. Hydroxyurea has been a game changer for over the last 3 decades and more in decreasing illness and death associated with sickle cell disease. And we need to examine and then respond to barriers to its use in our communities, so we can continue to improve outcomes in our patients. And that's it. Thank you so very much for listening.
Okay, thank you, Professor ASNANI, for such a wonderful presentation. I'm not sure if there are any questions just yet in the chat, but one of the things that I do remember, and if anyone is supposed to ask me about the drug, I remember you saying that it is a game changer, which is very important, right? And the other thing that I took away from your presentation is the fact that it lessens the amount of painful crisis that one who is living with the condition will experience. And we all know how it impacts persons going to school, how it impacts your social life, how it impacts your work life. And so it is definitely a game changer. If it is that you can find a medication that is now available that prevents you from stopping from work for long hours or a long time period, this is good. Because like I for myself, I know that whenever I'm sick, like last week I was having a crisis and it lasted for 1 week. However, I pulled myself together and hopped my way into work whenever I could. But if it is that you find that there are things that can minimize this, because the pain is real, as you mentioned, it's debilitating, the pain is real. So if there are things that can assist us in living a better life, in being more comfortable, then I thank you, we welcome it. And I encourage other persons to really find out when you visit the unit, or if you go to private doctors or wherever it is that you go to seek medical attention, ask about the drug to see if it is that you are a suitable candidate or if your child is a suitable candidate for the drug. And as Professor says, you're free to call the unit, the sickle cell unit, to ask any questions that you have if it is that you are not able to do so at this point in time, because there are persons who have the skill and the competence there who are willing to assist. Still no questions?
All right, this isn't a question per se, Jebby. This is just confirming and putting my experience out there. Can I say that yes, it is certainly a game changer. Now, this is my hydroxyurea. I have my hydroxyurea here. And can I tell you, in primary school, in high school and so forth, my eyes were very yellow. And it was a bit embarrassing, you know, because they would tease you and so forth because they don't understand. Right. No, since I started taking my hydroxyurea, I think I started this in probably my mid-20s. And can I tell you, I don't see the yellow eyes anymore. I feel more beautiful. The pain is lessened and all of that. So it is certainly a game changer. And I'm seeing more. I am actually seeing, you know, they usually say that the eyes are the window to the soul. And can I tell you, I am actually seeing me, you know, without seeing these yellow eyes because of hydroxyurea. And yes, I have to put my hydroxyurea box out there because this is actually my game changer. And can I say to you, Dr. ASNANI and the sickle cell unit, I thank you so much. Right, they have been there for me. I call them my earth angels. They have been there for me. They advise you how to take the drug. They are there. They do the testing and all of that. They have really been there. And can I tell you, they have made sacrifices where the families are concerned, and they are there at the sickle cell unit tending to our needs. Yes, and I have to say from the bottom of my heart, no words can express. Yes, and this is coming from a deep place. I'm so passionate. I love my doctors. Yes, and from the beginning, I've been saying my doctors because they are yes, they are your doctors, but they are particularly my doctors. They are my savior. And so forth. And can I tell you, my family, my mom is here right now, Miriam. And can I tell you, all the knowledge that she has garnered came from the doctors at the sickle cell unit. And I can tell you, I know that this is just thanking you so much, Dr. ASNANI, Dr. Knight Madden. I thank you and your team for being there for me and my family, right? So sickle cell is not just I am ailing with the disease, but my family. When I am sick, they would say, we are sick. And doctor, I have to say, thank you for introducing me to this game changer. And thank you for extending yourselves throughout the years, and they are still looking young. They have been looking after me for so many years. And can I say that they look so young, and I am going up there in age, but can I tell you, thank you so much, doctors at the sickle cell unit and the nurses. I love you so much, and thank you for introducing the game changer, not only to me, but to my family, right? To the Taylor family. I thank you so much, and I love you. I love you all at the sickle cell unit.
Tamara, thank you. Tamara, you just did my 45-minute lecture in 2 sentences. I'm going to put that on my slide for the next talk on hydroxyurea. It made me feel more beautiful. Yeah. So when persons with the disease talk about their own experience, it's much more powerful, because she spoke about something, the yellow eyes, you know, and that's amazing. So you just said my lecture in 2 minutes. Michelle just asked us talking over it.
Powerful, so impactful. You know, that's an amazing testimonial to sum up the reason why people should take up hydroxyurea. Powerful. Thank you so much, Tamara, for that testimonial. We have a few questions in the chat. Prof, I'm not sure if you're reading or you wish for us to read.
Where am I to, which chat am I to look? Because it won't be the Zoom chat,
We're not seeing it, right?
It would be in the YouTube chat. So the first question I'm seeing here is asking, what is the treatment dose of hydroxyurea?
So the dose varies, as I was saying in the lecture, okay? We usually will start depending on when we decide to, when it is decided that we will need to consider hydroxyurea, certain tests are done before we start hydroxyurea. Typically, the dose for hydroxyurea is based on your weight, body weight, okay? Typically, we will start with either 15 milligrams for each kilo of your body weight to be taken in a day, or 20 milligrams per kilo of your dose, okay? So if you are a 20 kilo baby, okay, and we start you on 20 milligrams per kilo per day, you will get a 400 milligram dose to take every day. And then you're monitored closely by your doctors in the first few weeks to decide how that is showing good effects or any side effects. We monitor for that. And your dose really, the best thing for hydroxyurea is to get you to as high a dose as your body can manage, number one, and that shows the most benefit. And to look at the benefit, we do blood tests to look at how high your fetal hemoglobin levels are going, because the higher your fetal hemoglobin levels, the more is blocking the sickling in your body, and that's what you want, okay? So we have to balance, we monitor to balance what is the best dose that your body can tolerate and what's the maximum effective dose. What is it that is giving you the best level of fetal hemoglobin with that balance? So the dose varies for everyone, but we tend to start at 15 milligrams per kilogram of body weight per day, or start at 20, and it can go up to as high as 30, or the maximum is 35 milligrams per kilogram of body weight to take every day. It's taken once a day.
Okay, so we have some other questions. So, Professor, what about the use of erythropoietin?
Erythropoietin?
That's correct.
That's a totally different drug, okay? And it is not a sickle cell related drug. It is used in some persons who have sickle cell disease. Erythropoietin is a hormone that the kidney uses to help it, no, the kidney doesn't use it, but erythropoietin stimulates your bone marrow to make more red blood cells and increase your hemoglobin level. In persons who have kidney disease, so if you have diabetes or sugar, as we call it, and that affects your kidney, the kidney gets damaged from your diabetes, the kidney does not produce the hormone enough and your blood counts fall or your hemoglobin falls. Same thing in sickle cell disease. It can affect your kidney and cause what you were saying, Jebby, nephropathy or kidney disease, okay? And if you get kidney disease, it will not, your body will not have enough erythropoietin being produced, and so your blood counts will start dropping. So many persons with sickle cell who normally have their hemoglobin of say 8, for example, 8, right? If their hemoglobin is at 8 grams and they get kidney disease, over time that hemoglobin level can start dropping from 8 to 6 to 3 or lower. And so we need to give them back this drug in the body, erythropoietin, right? So that drug is used in persons with sickle cell disease, but only in a specific way for those people whose hemoglobin is dropping because of kidney disease, and they are given erythropoietin just to push that bone marrow to produce a little bit more hemoglobin.
Okay, thanks for that, Prof. Another question. Does the hydroxyurea help with leg ulcers?
So that evidence is not very clear, okay? So you know how we gather evidence. We have persons with the disease who are taking it, and they have to be examined over time, over the years, okay? Now, if leg ulcers in a patient with sickle cell disease are caused by their disease, which we believe it is because of the disease, then hydroxyurea should help those as well. So I would say, even though the evidence is not 100%, like we have the evidence for painful crisis, we have the evidence for acute chest syndrome and its good effects, the evidence for its use in leg ulcers is not that clear. But me as a doctor, and you come to me with recurrent leg ulcers really bothering you, I will encourage you to try the hydroxyurea. We must try it for a few months and see if it's starting to show benefits.
Okay, thanks for that. There are some questions here, or someone is interested in the use of iron and folic acid in sickle cell patient. Are there any guidelines? Who needs iron and or folic acid?
So I said folic acid on the slide, okay? Folic acid is needed by the bone marrow while it's doing its work. The bone marrow is your factory where blood is produced, okay? And you know what the marrow is the soft part, the fleshy part inside your bones. If you eat a chicken bone, you break it, you see the red part, that's the bone marrow. That's the factory. We all have it in our bones as well, where blood is produced, and folic acid is one ingredient that's needed. And because sickle cell people's red cells are dying very quickly, their factory needs to work harder, and they tend to have the need for folic acid. But folic acid is commonly found in our foods, especially fresh fruits and vegetables. And most persons living with sickle cell disease who have a healthy, balanced diet, which includes fruits and vegetables on a daily basis, will not need to take folic acid. However, persons with sickle cell disease who are having recurrent crisis or just going through a little bad time, say 3 months, they're in and out of hospital, or they get acute chest that lay them up in bed for a couple of weeks, we will put them on folic acid for a while. So everyone with sickle cell does not have to take folic acid. Iron is a different issue. Sickle cell anemia is not caused by iron deficiency. A lot of times worldwide, and even in Jamaica, we think if we have anemia, which is just a low hemoglobin, then we must need iron. This is what we grew up hearing. And it is true for many of the anemias, but not for sickle cell disease. In fact, a lot of persons with sickle cell disease may have too much iron in their body. There are some persons with sickle cell disease who will need iron, but only your doctor can tell you about that if he or she is suspecting that your iron may be low, and we can see that picture in the blood, and we suspect iron, we do the iron studies, your iron is indeed low, then you will be put on iron. Do not go out there and buy iron and start taking it unless your doctor has advised you to take it. Please don't do it.
Thank you so much for that, Prof. Another question
I should step up now because my immediate ex-boss is right here watching me perform.
So, okay, Prof. Knight Madden, you're invited to give your feedback, give your input. So, is there anything else you want to add before the next question?
No, you know, Jamaica, we have fruits and vegetables available, and really, if people eat green leafy vegetables, then they'll get a lot of folic acid. There are children who have problems with their spleens, where because the spleens are enlarged, they break their red cells down even quicker than usual. And, you know, they can be picky eaters at certain ages. In that setting, we would give folic acid as well. But we don't universally ask all our patients to take folic acid. And we go as far as saying, if you're giving your child a multivitamin, find one that does not have iron in it. You know, so it's not just a matter of not going out and buying iron. If you're going to use a multivitamin, use the one that comes without iron. But, you know, my boss is doing a great job, so I'll hand back over to her.
It's a team approach. Okay, so here is another question. What are the baseline tests that need to be done prior to starting hydroxyurea?
So at the very least, we're going to check your blood count, your hemoglobin, your white cell counts, your platelets. We're going to check your liver functions. Okay. This is also a blood test. We're going to check how your kidney is functioning, because if this liver has any abnormalities, we have to be cautious. If there's kidney damage, we need to be cautious. Also, we need them for baseline, right? The other thing we look for before starting, or we would love to have, we don't have to wait on that result. What we would love to have is a fetal hemoglobin level. That's not widely available. You can't really walk into just any lab. It's not that easily available, but it is available. We would like to have that as a baseline before we start. There are some other studies we do. We do a hepatitis panel. But really and truly, the most important ones are your complete blood count, your liver function studies, and your renal studies. Prof, anything I'm missing there? We used to do a lot more, but we are not that insistent anymore.
It also depends on what your indication is. So clearly, if you're going on it because of having had a stroke, clinically, we would want to actually see imaging of the brain. And if you've had a lot of lung problems, multiple pneumonia, acute chest, we may want to do your lung function just to see what the baseline is. But most people will start hydroxyurea because of pain. And in that case, then the routine test would be ideal. So what we want to do is, we want on one hand to be safe, and on the other hand, not to be excessive in terms of the expenditure we're asking people to make. So decreasing any barrier from cost is important.
Okay. So another question here the person is asking, why do we use antibiotics with hydroxyurea?
So one of the, and I showed you on that side effects slide, one of the effects of hydroxyurea is to drop some of your blood counts. It can drop some of your white cells. It may predispose you to infections, okay? And so we typically used to put people on penicillin prophylaxis, penicillin with it, and if you're allergic to penicillin, then some other drug would be used. We also used to typically put people on folic acid while they are taking it. Also, again, because it may suppress the bone marrow. That's one of the ways it actually works, because people with sickle cell tend to have pretty high white cells, and people with sickle cell disease who have high white cells at baseline tend to have more severe disease, and hydroxyurea will work to reduce white cells, but we will, so we cover with any kind of antibiotics. Sorry, I'm losing. Yeah. Is that good? Can you hear me?
Yes, we're hearing you.
We're hearing you, Doc.
Are you ready for the next question, or you still have more?
Okay. I'm seeing some. No, I think Dr. King is reminding me that antibiotic is no longer routinely prescribed for hydroxyurea. So, you know, one thing again, as Prof highlighted, that we are trying to reduce barriers as much as possible. And even with hydroxyurea use, there's huge amount of research going on. How can we lessen the burden that a person has? Close monitoring, what dose to start on. There are people who need for other medications. So wherever we are finding that we can manage without those factors to consider, lessen that burden, then those are being lessened. So for example, there are countries that are saying, like you asked, we spoke at length about what dose to start people on, and we change the dose as we monitor you to take you to a higher level dose, the highest level that you can tolerate, and that's the most effective. There are places that just don't have that capacity or financial resources to do that, and they'll just have you on what is called a fixed dose, okay? So the need for other drugs, the need for close monitoring, all of that is lessening as we learn more and more. But we at the unit still encourage close monitoring. okay, for our patients. We still encourage, we have lessened much of the screening that you just asked about, Debbie. What are the tests that are needed before we start hydroxyurea? We've lessened that a lot, but so we are balancing, weighing and balancing. So the need for antibiotics is also cut out.
Okay, all right. So we have two related questions. So we mentioned the need for a care home. And this person is asking if the patient has defaulted at the sickle cell unit, can hydroxyurea be given in a private office, or will this have to be administered at the unit?
No, 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 no. So, couple of things. It is totally unfair that a person is living, Jamaica is pretty tiny, okay, but yet a person living in, say, Westmoreland should not have to travel to Kingston for routine monitoring visits, which may be every 4 weeks, sometimes at 2 weeks, they might need to come back, sometimes 3 months, okay? So the aim through the Sickle Cell Technical Working Group is that this care must be available where persons with the disease are living. So they do not need to be managed by the sickle cell unit. So that is the purpose. The guidelines were written for that purpose, to really support healthcare professionals in other parts of the island to be able to use this drug. And that's what I was mentioning. If they are able to pick up the phone, if they have a complicated case with hydroxyurea and they want to have a discussion, and we do that discussion even among ourselves, right? I may call Prof. Madden or Dr. King or Dr. Chin, any of the other doctors, and say, what do you think? I have this patient with so-and-so, what do you think we should do? And they should be able to do that. So number one, your general practitioner can start and continue hydroxyurea. Once both of you decide to do it, we can support if any support is needed. But many times that support won't be needed. Sickle cell disease should be no different from any other chronic illness such as asthma or diabetes or hypertension that is managed in public healthcare facilities as well as by your private physicians.
Okay, because another question came asking, can patients be monitored at other clinics and private doctors on the island? How do we get that information out on, you know, other clinics, other private practitioners?
Can they go?
Who also monitor the use of hydroxyurea?
I think we need to do it the flip way. So Maurette, we know you're living with sickle cell disease, and suppose you're living in St. Mary and Dr. Brown is your physician, your GP. You are to ask Dr. Brown, I would like to start hydroxyurea. Can you help? And then that conversation begins. Dr. Brown will say, yes, of course, Maurette, I'm quite fine. Let's talk about it. What are the indications and A, B, C, and D? Or Dr. Brown may say, let me talk to my colleagues at the sickle cell unit or another colleague in MOHW who is using hydroxyurea. So the conversation, I think, should be flip side. I don't know, Prof. Madam, Dr. Lord, if you want to say anything to that. I don't think we have hydroxyurea centers in other parts. We may have some sickle cell clinics in other parts, but you want to add anything there?
Well, we are trying to get to where we'll have care homes across the island in different parishes, but we haven't gotten there yet. I just want to stick a pin and say it's not that we're firing our patients and trying to get rid of them. We're happy to look after our patients as always. It's just that access is really an important right when it comes to healthcare. People, if you can't afford the bus fare to come to town, you shouldn't be without healthcare. And that healthcare should be the same quality wherever you are. And Dr. Lord's leadership has really been very, very powerful in getting things done so that we can move towards that goal of having healthcare homes right across the island. So right now, one of the things we're working on is actually to get hydroxyurea prescription even in health centers more easily than it is now. And that will be an important step forward. So what we want is that wherever you are in Jamaica, whether you go public or private, you have access to the same level of care and that would include access to hydroxyurea. Dr. Lord?
All right, I do agree with you, and I must admit that with all the facilities that we have offering care to persons living with sickle cell disease, the sickle cell unit or care have been dedicated to training our healthcare workers within these institutions to help to manage sickle cell disease, and that includes the introduction of hydroxyurea use within these facilities. So when you go to your health center, for example, where they have a specialist doctor visiting that will take care of you with your sickle cell, as Prof. ASNANI has indicated, you can start a discussion there. Say, well, listen, I would like to start hydroxyurea. We've been hearing of hydroxyurea. Can I start it here with you? If they say that they're unable to do so, then you say, well, listen, please reach out to the sickle cell unit for some guidance, but I would like to stay here where I'm at home, and you can manage me with their guidance.
Thanks
Over.
for that. My question was, what if the doctor is, not as confident and is a bit cautious? But you've said in that case, they could reach out.
Yeah,
to
that is why the sickle cell. Yes, the sickle cell unit is very famous and known to hold in the doctors and healthcare workers' hand along guiding care for sickle cell disease. They hold the hands. If they're uncertain, they will hold the hands and bring them on. Over.
And there are resources because the clinical care guidelines are available. The ministry has bought hundreds of copies. And also, we did a series of talks on use of hydroxyurea led by Dr. King, and those are available to all healthcare workers on the Ministry of Health website. So there are resources, and then people can always call it. I mean, this has been going on for decades, right? Where we will co-manage with people. There's some places like, for example, St. Anne's Bay Hospital, where we've been managing children together for a long time. They'll go to St. Anne's Bay most of the time and maybe come up to town once a year or something like that. And then over time, we hand them over completely unless there's a problem. So, access is key. And it's not that we're saying access a different level of care. What we're saying is that we increase the capability and confidence of the staff across the island so that wherever you are, you can get care.
Okay, powerful.
I want to add one more thing to that, Moret. Sure. One more thing. So I'm a GP, right? I'm a GP, and which means I can see anything coming into the office, right? And not just sickle cell disease. So, and there can be questions I have. So I might have a person with diabetes in front of me who is just a little bit more complicated. And I would have to find a specialist to call and say, what do you think about this? I have a case A, B, and C. This is what's happening. This is what I'm doing, but the sugar is doing A, B, C. What do I do next? The same with this. And the second thing I want to say is for patients and families with sickle cell disease, even if, and we do have patients who will leave wherever and insist that they're going to come to the unit and they know they're most welcome. But I would still want to remind them, it's fine for you to come to Kingston for your routine care, but wherever you live, and we can be your only doctor, but try have a facility that understands your chronic illness near to you, because we don't open on the weekend. We don't open in the night. So it's good that if you have a health center near you who can manage you at times during a hurricane when you can't reach Kingston because the road block up, whatever. Even if you decide sickle cell disease, sickle cell unit is your medical home, you try have another doctor who knows your situation near to you, who can quickly manage you. And there are many other reasons, but it's critical. And that is a dream that everyone, every healthcare provider should feel as confident, Moret, as you say the word confidence, in managing sickle cell disease. And I must say, not because I work at the sickle cell unit, that there's been a lot of outreach and work over the years with ministries backing to really support that networking with other healthcare providers.
Right. And just to add, part of the work of the Sickle Cell Technical Working Group is healthcare worker training and training in hydroxyurea right across the country. So that's in place and that will continue.
So if I may, it's just to say, just to remind our patients living with sickle cell disease and our practitioners, general practitioners, we have every parish, we have the sickle cell coordinators, and there's also a regional coordinator at every regional office, regional health authority office. There's a sickle cell coordinator there. Some of them, even the persons who coordinated non-communicable disease, the NCDs, and that's headed by Dr. Skyers, they also will have this information that can share with you as it relates to the way you can get help. All right, so that's the important thing. You must know that help is just a call away. Over.
Very good. In fact, we have a question here that says, are the Sickle Cell Unity members going to be doing outreach and presentations nationally, especially in the Sickle Cell Awareness Month? Or can this be arranged for any time of year?
Who must answer that? Me? Well, we were scheduled to have a training with the Northeast region tomorrow. And whenever, because we can't really jump up and say, I come in to teach you. Who is you to come teach us? But once there is a reach out, I know Dr. King, Prof. Madden, and the Sickle Cell Unit, or through the technical working group, it can all be done. But with technology today,
that's correct.
These kind of events are recorded. This is going to go on the minister's YouTube, whatever technology platform. There are videos on the website. I think Prof. Madden has done a few videos and there are others. But if you think you have a group of healthcare providers, and we're not talking only doctors, but nurses, etc., right? Because a lot of interaction of patients is with nurses. A lot of persons don't feel as easy to just reach out to a doctor and ask them a question as they do with nurses. So it's important for all of them to have to understand hydroxyurea and sickle cell disease. So I don't know if I've answered you, Moret, but
I think persons are particularly interested in, private medical officers. So how do we extend the knowledge across the different regions, both for the private as well as public sector healthcare workers?
Yeah. Well, for the private, we can work through, we have
the Medical Association of Jamaica or some other partners.
Yeah. And we have sent out this exact flyer as well to those organizations, but sometimes, it doesn't reach everyone, but we are just a call away. We spend a lot of energy and time because we are really passionate about increasing knowledge and confidence in managing this illness, which is a little bit rarer than the much more common pressure and sugar and those illnesses. So there's a little less.
So that's definitely an area we can partner with the MAJ on. I know Dr. James has shown keen interest in the work of the foundation and the sickle cell community. So we could partner with him on that. So following on Dr. Lord's comment, there's a question: who are the sickle cell coordinators? And
all right. In terms of the sickle cell coordinators for
the regions.
For the regional coordinator for the Southeast region, we have two coordinators, mainly regional coordinators. We have Lorraine Hyde Allison, supervisor family nurse practitioner at the Southeast region. And we have Dr. Gordon Robinson. So once you get the Southeast region, you can call for those two names. When we speak to the Northeast region, you can call for Nurse Spencer the Kid. All right, she's the regional nursing supervisor at the Northeast region. And so she'll be able to assist you there. When we call for the Western region, you can call for two persons for the Western region. You can call for regional nursing supervisor, Nurse Binns Watson, or you can call for Dr. Johnson Campbell, and they're both at the Western region. And at the Southern region, you can call for two persons mainly. You can call for Dr. Hannah, Yassine Hannah, and you can also call for the regional nursing supervisor, Johnson Griffiths. And so those are the persons you can reach out to at the regional level. I know that within the 13 parishes, there's someone there. And there's
Okay, and
also
there's
Dr.
Dr.
Marcia
Marcia
Campbell.
Campbell in Europe, right? But Dr. Lord, I think this is an excellent opportunity to have this information posted on the website so persons can access it.
Okay, all right. We will work towards that.
Okay, great. All right, so I think I have 2 more questions. And a query here, Prof. Asnani, what caused your nail and body to get black when taking hydroxyurea? Actually happen?
Your body, I am not sure about the body, but yes, you may get some darkening of the nails with it. You may get some darkening of the nails, you may get some hair loss. So a couple of these side effects can occur.
Are they reversible or they're permanent?
I'm not sure. I think the darkening of the nails, I mean, we wouldn't want people to stop hydroxyurea just for that, right? I don't think that's one thing, because that's not, you know, anything critical. It may be cosmetic, but we wouldn't want patients to stop. So I guess it depends on how chronic it has become. If hydroxyurea is taken off for some other reason very quickly, then it may revert. But I don't even think it happens. I definitely have not seen many cases of it. Let me ask Dr. King if she has seen many cases of this. I don't think so. Prof, you have seen many cases of darkening of nails? A few.
Yeah, there have been a few. And some people are relatively upset about it. But I mean, you know, when you look at the benefits, then the benefits outweigh the complications.
Cosmetic.
Yeah, so Dr. King also says the same, may have some reversion, but not necessarily. And it's not everyone is going to get any of these side effects, by the way.
Like with any other medication. Right. Okay, I'm not very clear on this question, but it says, do you think it is good to give hydroxyurea to a person that cannot express him or herself?
In a child?
I wondered if it's a child, is this somebody who is mute? You know, is it an issue of consent?
I mean, if it's a child, I mean, as a pediatrician, most medications that you give to the children, it's not that they necessarily consent. The parents consent on behalf of the child, because it is agreed by the parent and the provider that this is of benefit to the child. Now, in terms of persons who have had strokes, who may not be able to communicate, we know that some of the evidence in the literature actually comes from here, way back in the days of Dr. Ali, which showed that using hydroxyurea decreases recurrence in stroke, and children who have recurrent strokes are the ones who quite often end up very disabled. So in those settings, then it would be appropriate to use hydroxyurea. So I'm not sure if that's what the person was getting at. Not sure if we're answering their question completely, but yeah.
If I could also add on, so for any chronic illness management, it's very important to have what we call shared decision making, right? It's not the doctor to say, here's a prescription, go home and take it exactly as I wrote it. But I'll have to sit down and talk to the person and let them understand why it's important, because all this shared decision making improves adherence and improves outcomes. Okay, if I cannot dispel your fears or worries or concerns or non-motivation, then our partnership may not be very effective, okay? So it's important to get that kind of consent, or agreement is a better word maybe, right? That a person with the disease who is being offered hydroxyurea should understand. But but it's a standard of care. It's like for any other medication, you know, you go to the hospital, or your mother brings you in because you wheeze at nights, and the doctor says, hey, Zapof, we need you to take it. And as Prof said, for children, is a parent going to really is actually going to use it for the child, or have the child take it. But this is a key factor for hydroxyurea, you know, because hydroxyurea is a long-term treatment, and a lot of times it started in childhood. And really we find when the adolescents, you know, when the children start aging, going into teen years and older teens and young adulthood, a lot of those children who have been doing very well on hydroxyurea start dropping off, because maybe because they have been taking it for years, the doctors may not remember that we now need to start engaging this teenager more and more, so the teenager, him or herself, becomes comfortable and confident and sees the need for taking this hydroxyurea. We have taken the opportunity on that question to say a lot more other different things about hydroxyurea.
And that's fine. Is there an impact if there's not consistency in taking hydroxyurea? So I fall off for some days. How will that impact?
It might impact mostly in that your levels of hydroxyurea, etc., you know, might not be as effective, but there's no bad effect, other than the fact that you might end up in a crisis if you missed it for many more days, or etc. You get me? But there's no other medical side effect other than just the disease going out of control that I can think of. Jennifer, you can think of anything? No.
There's no rebound as such to say, okay, I come off it, so my pain comes up. No, but if you come off it and your hydroxyurea impact goes down, then the sickle cell itself may cause you to have pain because you're no longer protected by the extra hemoglobin F.
Okay, understood. So we have a suggestion for that person whose nail becomes black. So the suggestion is nail polish, and this is endorsed.
What about if that's a guy?
Okay, so we have another question. And this is hydroxyurea being available in public pharmacy. Can we speak to that?
What about it?
Is it available in public pharmacy, or is it because the NHF supports hydroxyurea? So the question is, can it be accessed in public pharmacies?
Like DrugServe, yes.
Public,
yes.
Right. So any ordinary
in DrugServe,
okay,
right?
DrugServe, right?
In the and those would be in the hospitals. Now, you know, you have to understand this, how NHF drugs are stocked in pharmacies. So we know that some pharmacies stock it more than others, right? And so patients become aware of the places where they can most easily access it, where they usually have stock, and they go to those more frequently. But it is a part of the offering of DrugServe. You can use the app and send in your prescription direct to DrugServe, and rather than have to wait. And sometimes if they're out in one location, they might be able to advise about another location. But it is certainly one of the offerings there.
This is one of the questions we want to answer as well with our study that we are putting together, because the NHF gave us some just very basic data, and it said that a lot of the prescriptions or a lot of the hydroxyurea is being used more in this part of the island, meaning Kingston, St. Andrews, St. Catherine, these parts of the island, and not in the other areas. So really and truly part of this research study will be to explore where pharmacists have it, but it's definitely available at the DrugServes and so on, right? Where it would be free, of course, because we do have universal health care. I don't know if every pharmacy stocks it, because every pharmacy just does not stock every drug anyway. I think that if a pharmacy, say near to the sickle cell unit, knows that a number of sickle cell patients come there, they definitely will stock it, you know. So I guess they have their own ways.
So it's accessible across different public pharmacies, is what you're saying.
It should be accessible across the island.
Right. Good.
And NHF is quite responsive. So if you are going to a drug serve and you're not being able to get the hydroxyurea, you can actually call into NHF and say, listen, I'm not getting it, and they will make adjustments as necessary.
Okay, as we wind down. So there's one comment for Dr. Lord, and the request is that we post the contact numbers for those coordinators once they are posted online. Okay, so Prof. ASNANI, there were lots of commendations for you, and we didn't talk about that, so I want to highlight some of them. So, you know, we're hearing, we appreciate this, and we want to thank the Ministry of Health and Sickle Cell Unit, and I might add the Sickle Cell Support Foundation for providing us with this webinar. And we're hearing as well that this was excellent, very informative presentation. I'm going back up short and spicy and stimulating from the professor. Many thanks as well. Thank you, Professor ASNANI, for this comprehensive, excellent, and informative presentation. So that sums up the feedback that we've been getting from this lecture today. I'm seeing Prof. Knight Madden's hand raised, Prof.
Yes, I just want all our patients to know, all the people living with sickle cell and their parents and families, that we have a very, very effective representative on the sickle cell technical working group called Miss Moret Wright. So please feel free to forward any concerns you have to the technical working group through her as well, because she very ably speaks up on your behalf. And we really appreciate her input into the technical working group.
Okay, Prof.
I have my hand raised. I have my hand raised. We're out of time.
The lecturer hand is raised. Okay, okay, Prof.
I have to say one thing, is that building upon what Prof has just said, that please, persons living with sickle cell disease and parents of children with sickle cell disease, please come on. Moret might kill me and Camille might kill me. Come and join the Support Foundation, because that is where you're going to get your real support. You see, Tamara said in 2 sentences what it took me 45 minutes to say. The good effects. Jebby, please make a plea for that. I really, really wish for persons with the disease to be engaged with their peers, because there's nothing like that to really empower you in your journey with sickle cell disease. So.
Okay, and with that said, Jebby, it's over to you to provide the closing remarks. I mean, I'm heartened by the quality of the presentation and the feedback. There are just so many questions. And Prof, you didn't just think that all the resource or the knowledge resided with you. You called on your former boss. And so that team really enriched the conversation. So thank you so much, Prof. ASNANI and Prof. Knight Madden. So Jebby, over to you.
All right. As Moret would have said before earlier, you know, it was a very comprehensive and stimulating presentation. One of the things that stuck out for me most of all was when Prof said, I will put my head or my neck on the block for this medication. No, that is not something that you hear all the time. And when someone can say that with such certainty and assurity, it means that she stands behind this game changer, this drug that will transform the lives of persons like myself who are living with the condition. We would have heard about the support that you have, that you can access, whether it's through the foundation, through the unit, or in our clinics across the island. Dr. Lord would have notified us of all the persons that you can contact, you know. And as Prof says, no matter where you go, regardless of the fact that you're before a general practitioner, nobody knows everything, which is what is key, right? So therefore, at some point in time, our doctors will have to call on their colleagues for, you know, expert advice in the areas that they primarily practice. So do not be heartened by the fact that you live outside of Kingston and St. Andrew or St. Catherine, and you may find it hard, or you have to come to the clinic once a year for your checkup. We have persons in the parishes who are equally as competent. Dr. Madden would have said it, that we are doing the trainings and the brochures and the booklets that are available to other medical practitioners. So don't be disheartened. But once again, I thank Prof. and Tamara's testimonial. How can we go over that? I mean, who is best to talk about something than someone who is actually living and experiencing the use of the drug? I mean, she really touched my heart. She really, really touched a part of me. You can see that it was a speech that came purely from inside. She talked about the support that is offered. I can't attest to the use of the drug, but I can attest to the support that the unit has given me or has provided me and my family over the number of years that I have been coming to the clinic. So yes, we have a very good team there. Dr. Madden, Prof. ASNANI, Moret, Dr. Lord. I want to thank you all on behalf of the sickle cell community for really taking the time out to come and share, to come and enlighten us, and to let us know that, guess what, beyond our immediate support system, we do have an extension, an extended family who still cares, who is there to offer us support in whatever way it is that we need. Morit, thank you for doing such a tremendous job. I mean, Camille is not here, so let us apologize for her absence, who is the other co-founder of the Sickle Cell Support Foundation. I want to thank you guys for sharing, for having that vision to provide this support to other persons. And I remember, what was it, around 4 weeks ago or 3 weeks ago when you launched the mentorship program. One of the things about it is that persons like myself who are older, we didn't have the benefit of some of the things that are happening now. So it's 30 years of greatness. We are thankful. We look forward to many, many more. And that's, you have laid the foundation for the younger generation who will
definitely
come on board. They have a solid foundation and platform to stand on. So once again, thank you. I thank you, persons and from the virtual world who have taken the opportunity to join us. We thank you once more, and I do wish everyone a wonderful evening.
Thank you, Jenny. Great job, everyone.
All right, thank you so much.
Bye-bye.
All right.
Thank you.
Bye, guys. Bye-bye.
Bye.